My name is Thiele, and I chose to research gestational diabetes mellitus. Gestational diabetes mellitus is characterized by high blood sugar due to insufficient insulin production during pregnancy. The reduced insulin production causes glucose to be retained in the blood instead of being converted into energy. The buildup of glucose in the blood is referred to as hyperglycemia. Some risk factors include overweight/obesity, minimal physical exercise, poor diet, women who are 35 years or older, polycystic ovary syndrome due to the insulin resistance in pregnancy only heightens the glucose intolerance in the body. In addition to PCOS, gestational diabetes mellitus during a previous pregnancy and family history of diabetes also are risk factors. Gestational diabetes screening is typically performed at 24 to 28 weeks gestation. Screening will be performed closer to 24 weeks if there are risk factors present, but if there are no risk factors present, screening will often be performed closer to 28 weeks. The 1-hour glucose tolerance test is the initial glucose tolerance exam used to diagnose gestational diabetes. The pregnant woman will drink a 50-gram glucose solution, have their blood sugar checked after 1 hour. A blood glucose level that is greater or equal to 140 will require an additional blood glucose test to determine the presence of gestational diabetes. The 3-hour glucose tolerance test is the additional blood glucose test. The pregnant woman must fast prior to the exam and have their fasting blood glucose level checked. Following the fasting blood glucose level, the woman will drink a 100-gram glucose solution, have her blood glucose level checked 3 times 1 hour apart. A diagnosis of gestational diabetes is made after 2 abnormal blood glucose levels. Abnormal blood glucose levels include fasting of greater than 95, after 1 hour greater than 180, after 2 hours greater than 155, and after 3 hours greater than 140. If the blood sugar level is less than 140, then the pregnant woman is considered to have a blood sugar within normal range. As far as treatment for gestational diabetes, it is important to monitor blood sugar routinely. Typically, it is done 1 to 2 hours after each meal and at bedtime. You may monitor blood sugar in the middle of the night if insulin dosage is changed or if diets are changed. It is important to monitor the growth of the baby via ultrasound. Routine physical exercise must be implemented, which is also characterized by 30 minutes of moderate intensity aerobic exercise at least 5 days a week, or a minimum of 150 minutes per week. A healthy diet is implemented in order to decrease carbohydrate intake. A diet is individualized to the patient's body mass index. Carbohydrate intake is typically limited to 33 to 40% of calories, while protein accounts for about 20% and fat accounts for about 40%. In addition to implementing a healthy diet, it is important to make sure a mom with gestational diabetes always carries a snack with her, such as a granola bar, to prevent hypoglycemia. Insulin is the preferred treatment option. Rapid-acting insulins have a fast onset and peak effect. They're mainly used to prevent hypoglycemia between meals, and they're injected immediately before mealtime. The effects only last typically about 3 to 5 hours. In addition to rapid-acting insulins, long-acting insulins are used to release small amounts of insulin throughout the day and were designed to mimic basal insulin secretion. In addition to insulin as a treatment, Metformin is used to decrease hepatic glucose production and increases sensitivity to insulin. Lifestyle modification is a major component in preventing gestational diabetes. Exercise, such as weight training, is important because it increases lean muscle mass and improves tissue sensitivity to insulin. As far as implementing more regular exercise, it is also important to have 150 minutes of moderate intensity aerobic exercise per week. For example, walking for 10 to 15 minutes after each meal can lead to improved glycemic control. Likewise to the treatment, a healthy diet is important to prevent gestational diabetes, and it can also serve as a means to lose weight if it is necessary. Potential fetal complications. Shoulder dystocia often occurs due to fetal macrosomia. Macrosomia is defined as birth weight more than 4,000 to 5,000 grams, which puts a baby puts them greater than 90% in a greater than a 90 percentile for their birth weight. And macrosomia occurs due to poor glycemic control. Fetal/neonatal cardiomyopathies can occur. Respiratory problems. Hypoglycemia often occurs at birth because the fetal pancreas begins to respond to the maternal hyperglycemia by secreting large amounts of insulin at 10 to 14 weeks gestation. Polycythemia occurs as a result of the increased metabolic rate from hyperinsulinism. The hypoxemic state causes the newborn to increase red blood cell production, and the polycythemia increases blood viscosity, which causes circulation impairment. The increase in red blood cells to be hemolyzed increases the potential bilirubin load that the infant must clear, which increases the risk of developing hyperbilirubinemia. For potential maternal complications, preeclampsia can occur because the high blood glucose level can cause an increase in blood pressure. There's also an increase in likelihood of having a cesarean delivery because of the failure of fetal descent or labor progress due to fetal macrosomia. In addition, type 2 diabetes can be developed, and it is usually screened for between 6 weeks and 6 months postpartum via a glucose tolerance test.